So what is a specifier? It's extra information that makes a diagnosis more precise and more useful. When we say bipolar I, manic episode, that's the headline. The specifier fills in the rest of the story. How is this episode presenting and what pattern does this illness follow over time? DSM-5 TR calls them specifiers, ICD-11 calls them qualifiers or modifiers. Same concept, different label, and there are two types: episode specifiers, which describe what's happening right now, and course specifiers, which describe the pattern over years. Both appear in exams, both matter clinically. Think of it like this: the diagnosis is the postcode, and the specifier is the full address. You need both to actually find where you're going. Without the specifier, you have a rough idea of what you're treating. With it, you know exactly what this patient needs. Mixed features means both poles are present in the same episode simultaneously. If the patient is manic, they have 3 or more depressive symptoms on top of that. If they're depressed, they have 3 or more manic symptoms breaking through. This is the highest risk bipolar presentation. The patient has the drive and energy of mania combined with the despair and suicidal ideation of depression. That combination is what makes it so dangerous. Antidepressants are harmful in this state. They fuel the manic component. The treatment is mood stabilizers and antipsychotics. Antidepressant monotherapy is always wrong here. Here's how to think about the DSM mixed features table. The core rule is simple: 3 symptoms from the opposite pole. That's it. If someone is manic and you notice they're also expressing profound hopelessness, guilt, or suicidal thoughts, that's mixed features on a manic episode. If someone is depressed but they're also showing decreased need for sleep, pressured speech, or grandiose ideas, that's mixed features on a depressive episode. The threshold is 3 crossover symptoms. Not a full manic episode and a full depressive episode simultaneously, just 3 symptoms bleeding across. And they can't be explained by drugs or alcohol. The reason this changes management so dramatically is the risk. Someone with mixed features has both the energy and drive that comes with mania and the hopelessness and death wish of depression. That is a genuinely dangerous combination. Antidepressants in this situation can accelerate the manic component and make things worse. Mood stabilizers and antipsychotics are the safe options here. ICD-11 takes a slightly different structural approach to mixed features, and this is actually a neat exam distinction. In DSM, mixed features is a specifier you add on top of a mainly manic or mainly depressive episode. 3 crossover symptoms and you're done. ICD-11 goes further. It treats a mixed episode as its own completely separate type of episode, not just a flavor of another one. The ICD definition requires that both manic and depressive symptoms are substantially present simultaneously or alternating rapidly over at least 2 weeks. It's a higher bar for mixing. So in ICD, if you have a predominantly manic episode with just 3 depressive symptoms, you might not reach mixed episode threshold, but in DSM you would. The clinical management is the same either way. Avoid antidepressants, use mood stabilizers and antipsychotics, watch the suicide risk closely. Remember the image, storm and fog at the same time. The storm gives the patient the energy and the drive. The fog gives them the hopelessness and suicidal ideation. Together that's lethal. 3 symptoms from the opposite pole is the DSM threshold. ICD needs more complete mixing, and antidepressants are always the wrong choice here. Anxious distress means prominent anxiety symptoms are occurring as part of the current bipolar episode, not as a separate anxiety disorder, but within the episode itself. DSM has 5 specific criteria for this, graded from mild at 2 symptoms up to severe at 4 or 5 with visible motor agitation. When anxious distress is present, 3 things worsen: suicide risk increases, episodes last longer, and the illness is harder to treat. Quetiapine works well here because it's both mood stabilizing and anxiolytic. And the key exam point, ICD-11 does not have this specifier. It doesn't exist in ICD-11. That difference between the 2 systems is one of the most tested facts in this whole topic. 5 criteria, 2 needed, 4 grades of severity. That's the structure of the anxious distress specifier in DSM. Let me make these criteria feel real rather than just a list. Keyed up and tense. The patient describes feeling like they're vibrating internally, like they're always braced for something. Unusually restless. They can't sit still, can't settle. Difficulty concentrating because of worry. Their mind is running worst-case scenarios they can't switch off. Not just the racing thoughts of mania, but specific dread. Fear something awful will happen. an impending sense of doom, and feeling like they might lose control of themselves, which is particularly frightening for patients. 2 of those 5 symptoms, present most days of the episode, gives you the specifier. Severity grading goes from mild at 2 symptoms up to severe when 4 or 5 symptoms are present, and you can see visible motor restlessness, pacing, wringing hands, unable to be still. Severe anxious distress is associated with significantly higher suicide risk and longer episode duration. Clinically, quetiapine is often the drug of choice here because it has both mood-stabilizing and anxiolytic properties. Short-term benzodiazepines can bridge acute agitation. This is actually one of the clearest differences between DSM and ICD in the whole specifiers topic. And examiners know it. ICD-11 simply does not have an anxious distress specifier. Full stop. If a patient has a bipolar episode with significant anxiety features, ICD-11's approach is to describe those features in the clinical narrative, or if the anxiety meets full criteria for its own diagnosis. Generalized anxiety disorder, panic disorder, you code that separately as a comorbid condition. The DSM approach is to formally capture anxiety within the episode itself using the specifier. Neither approach is wrong. They reflect different philosophical frameworks for how to classify overlap between conditions. But for exams, you need to know which system has the formal specifier and which doesn't. DSM does, ICD doesn't. The exam hook here is the DSM-ICD difference. DSM has a formal 5-criterion specifier with severity grading. ICD-11 doesn't have it at all. It codes anxiety separately. That contrast is exam gold. And clinically, severe anxious distress with motor agitation is a red flag. It changes management and raises the suicide risk significantly. Melancholic features describe a specific, severe quality of depression, not ordinary sadness, not a reaction to circumstances. Something biological, pervasive, and fixed. The hallmark is non-reactivity. Even briefly, even with good news, the mood does not lift. Nothing moves it. Alongside that, there are biological markers. Mood that is worst first thing in the morning, waking at least 2 hours too early, and visible psychomotor changes. This subtype predicts better response to ECT and biological treatments. And ICD-11 has the same concept under a different name, the somatic syndrome, requiring 4 of 7 somatic criteria. Let's make melancholic features feel real. Imagine your patient comes in looking hollow. You ask how they're feeling and they say, and this is something clinicians hear, I don't feel sad exactly, I feel nothing, like the light's been turned off. That is the distinct quality of melancholic mood. It's not grief, it's not ordinary sadness, it's a biological emptiness. The DSM has 2 core criterion A options, either profound anhedonia, loss of pleasure in virtually everything, or non-reactivity. Non-reactivity means even if something genuinely good happens, the mood does not lift. Not even briefly. A patient who can smile briefly at a joke probably doesn't have melancholia. A patient whose expression doesn't change at all, that's the flag. Then criterion B, you need 3 more from morning worsening, early waking by at least 2 hours, psychomotor changes that are visible and significant, appetite and weight loss, and a quality of guilt that feels disproportionate or irrational. Why does this subtype matter clinically? Because it predicts what will work. ECT is highly effective in melancholic depression. Historically, tricyclics outperformed SSRIs in this subtype. It tells you this patient likely needs a more biological aggressive treatment approach. ICD-11 calls this the somatic syndrome, and that name is actually quite descriptive. The word somatic here doesn't mean medically unexplained. It means the depression has crossed from being purely psychological into having clear biological expressions in the body and behavior. Sleep disruption, appetite change, psychomotor changes, loss of libido. ICD needs 4 of 7 somatic symptoms. The list is essentially the same as DSM's criterion B. Anhedonia, non-reactivity, early morning wakening, worse mood in the morning, psychomotor changes, appetite and weight loss, loss of libido. 4 of those 7 and the qualifier applies. The one to notice is libido. ICD includes that explicitly. DSM's criterion B doesn't list it separately. That's a minor but occasionally testable difference. The clinical meaning is identical. This is a patient with a severe biologically driven depression who needs biological treatment. The one image that captures melancholia, A lamp that's broken, not dimmed. You can't turn it up by adding good news or a pleasant event. It's not reactive at all. That non-reactivity is the hallmark. DSM calls it melancholic features. ICD calls it somatic syndrome. Both mean the same patient, the same clinical picture, and the same therapeutic implication. Go biological, consider ECT. Psychotic features means delusions or hallucinations are present during the mood episode. Once you've established they're there, the critical question is, does the content match the mood? Mood congruent means the psychotic content fits the emotional state. Grandiosity in mania, nihilism and guilt in depression. Mood incongruent means the content has nothing to do with the mood at all, and that mismatch is a warning sign. Incongruent features mean a worse prognosis and should make you reconsider the diagnosis, particularly schizoaffective disorder. Both DSM-5 and ICD-11 use this congruent-incongruent framework. Think of it this way. If you're manic and you believe you're the chosen one with a divine mission, that makes a kind of psychological sense. Your mood is elevated, your sense of self is inflated, and your delusion reflects that inflated self-image. That's mood congruent. If you're deeply depressed and you believe your body is rotting away from the inside, or that you've committed an unforgivable sin, or that the whole world has ended, again that makes psychological sense given the depth of the depression. That's mood congruent too. Now imagine you're manic, and you're describing in detail how the government is inserting thoughts into your head. Or you're depressed and you believe that aliens are controlling your movements. The content has nothing to do with your mood state. That's mood incongruent. And that's the clinically significant flag. Mood incongruent features are associated with worse outcomes and should always prompt you to think carefully about the diagnosis. If psychotic symptoms persist between mood episodes, not just during them, schizoaffective disorder moves up the differential. Both DSM and ICD use the congruent-incongruent framework, so this distinction is examinable in both systems. Good news, ICD-11 and DSM are closely aligned on psychotic features. Both use the qualifier, both distinguish congruent from incongruent, and both flag the same diagnostic boundary. Psychosis between episodes moves you towards schizoaffective disorder. The main thing to know about ICD-11 specifically is that psychotic features are coded as a qualifier attached to the bipolar episode. It's structurally a bit different from DSM, but the clinical meaning is identical. The congruent-incongruent distinction is the thing examiners test, and it's the same in both systems. So for this specifier you don't need to memorize two different systems, understand the concept once and apply it to both. Congruent or incongruent? That's the only question that matters with psychotic features in bipolar. Congruent is expected and fits the mood. Incongruent is the flag. Worse prognosis, higher diagnostic uncertainty, and schizoaffective disorder sitting just across the boundary. If psychosis persists between episodes, you've crossed that boundary. Catatonic features are striking motor abnormalities occurring during a mood episode. And here's the fact that surprises most people. Catatonia is more common in bipolar disorder than in schizophrenia. It's just under-recognized. DSM requires 3 of 12 features, ranging from complete stupor at one extreme to frenzied purposeless agitation at the other. The classic trio for recognition and exams: stupor, waxy flexibility, negativism. First-line treatment is lorazepam. A good response actually helps confirm the diagnosis. And the critical safety rule: antipsychotics can worsen catatonia and trigger neuroleptic malignant syndrome. They are not first-line. That is a patient's safety non-negotiable. Catatonia sounds exotic, but it's something you will see in clinical practice, especially in acute psychiatric inpatient settings. And it's underdiagnosed in bipolar because people assume it only happens in schizophrenia. It doesn't. Let's walk through the features in plain language. Stupor: the patient is lying completely still, unresponsive, like a statue. Waxy flexibility: if you lift their arm and hold it above their head, it stays there, like warm wax. Hold it at a strange angle and it remains. Mutism: complete silence even when directly addressed. Negativism: not opposition as in refusal for a reason. Pure purposeless resistance to any movement or instruction. You try to open their hand and they resist, silently, for no apparent reason. Then on the other end of the spectrum, catatonic agitation. The patient is in constant frenzied motor activity that doesn't have a goal or purpose. The 12 features range across this whole spectrum from complete stillness to constant movement. 3 of 12 is the threshold. Now the most important clinical point, and the one that gets people hurt if they get it wrong. Lorazepam first. It can produce a dramatic response within minutes. That response is actually useful diagnostically. If catatonia lifts significantly with lorazepam, you're more confident in the diagnosis. ECT is for cases that don't respond to benzodiazepines. And antipsychotics, do not use them first. They can worsen the catatonic state, and they carry a real risk of triggering neuroleptic malignant syndrome in a catatonic patient. NMS is life-threatening. ICD-11 has made an interesting structural decision with catatonia. It gives it its own diagnostic category, code 6A40, rather than just folding it in as a specifier on another condition. So in ICD, if a patient with bipolar disorder develops catatonia, you write both diagnoses, the bipolar diagnosis, and then separately code catatonia associated with another mental disorder. It's a comorbid coding approach rather than a specifier approach. DSM just adds it as a specifier tag on the mood episode. Conceptually, they're capturing the same patient. The clinical guidance is identical in both systems: benzodiazepines first, ECT for refractory cases, and careful avoidance of antipsychotics as first-line treatment. For exams, the ICD structural difference, its own separate code rather than a specifier, is the testable distinction. Lorazepam first. That is the most important clinical rule from this slide. Not the 12 features, not the coding difference. Lorazepam first, ECT if that fails, and never antipsychotics as first line. Antipsychotics in catatonia can be fatal through NMS. That safety rule is what examiners and clinical reality both care about most. Peripartum onset means the mood episode began during pregnancy or shortly after delivery. DSM-5 TR defines the window as onset during pregnancy or within 4 weeks of delivery. ICD-11 extends that to 6 weeks postpartum. That difference is tested. Why does DSM say peripartum rather than postpartum? Because around half of so-called postpartum episodes actually begin during the pregnancy itself. The most severe expression is postpartum psychosis, affecting between a quarter and half of all women with bipolar disorder, typically appearing 2 to 4 weeks after delivery, and representing a psychiatric emergency requiring immediate admission. The strongest predictor of it happening again, it happened before. The peripartum onset specifier tells you when the episode started, during pregnancy or right after delivery. This is not just a label. It is a red flag that places this patient in the highest risk group for severe psychiatric illness. The window in DSM-5 is pregnancy or within 4 weeks of delivery. The change from DSM-5's postpartum to DSM-5's peripartum was driven by data. When you look carefully at so-called postpartum episodes, roughly half of them actually started during the pregnancy. The mother was unwell before she gave birth. That's why the window was extended back into pregnancy. The most severe expression of this is postpartum psychosis, which in DSM terms is a manic or mixed episode with peripartum onset. It typically erupts within 2 to 4 weeks of delivery, rapidly and dramatically. Between a quarter and half of all women with bipolar disorder will experience it at some point in their reproductive years. That is an extraordinary prevalence. And the strongest predictor of it happening, a previous peripartum episode. That is your risk stratification question in any perinatal assessment. ICD-11 uses essentially the same concept but with a slightly wider postpartum window, 6 weeks rather than DSM's 4 weeks. This is actually the closer approximation to the WHO's definition of the postnatal period, which is also 6 weeks. For clinical practice, the difference is minor. For exams, it's a clean factual distinction. 4 weeks in DSM, 6 weeks in ICD, both include the antenatal period, both recognize the severity of postpartum psychosis, both recommend the same clinical response: proactive perinatal psychiatry involvement, close monitoring throughout pregnancy and the postpartum period, and a plan for rapid recommencement of mood stabilizers after delivery. The most important clinical fact for either system: if a woman has had a previous peripartum episode, she needs a detailed perinatal mental health care plan before she gives birth again, not a crisis response after. 4 weeks versus 6 weeks. That's the testable difference. But the bigger clinical point is that this specifier flags a patient who is at extraordinary risk. Postpartum psychosis in bipolar isn't rare, it's a near 1 in 3 chance. Every woman with bipolar disorder who is pregnant or planning pregnancy needs a perinatal psychiatry team, not just a GP appointment. Seasonal pattern means there is a regular, predictable link between mood episodes and time of year. The illness has a calendar. This is a course specifier. It describes a pattern over years, not a single episode. The classic bipolar pattern is depressive episodes in autumn and winter followed by hypomania or mania in spring and summer. The criteria require at least 2 years of this pattern, and seasonal episodes must outnumber non-seasonal ones across the patient's lifetime. Light therapy has genuine evidence for seasonal depression. It's the treatment specifically linked to this specifier, and the clinical principle is anticipatory management. Adjust the treatment plan before the vulnerable season arrives, not after the episode has already started. Seasonal pattern is the one specifier that patients often identify themselves before any clinician does. They come in and say, every October I start going down, every March I feel amazing, sometimes too amazing. And they're right. The specifier formalizes that observation into something clinically meaningful. For DSM, the requirements are a regular temporal relationship between episodes and time of year, at least 2 years of this seasonal pattern, and crucially, the seasonal episodes must outnumber non-seasonal ones across the patient's lifetime. You can't have one winter episode and call it a seasonal pattern. The classic presentation in bipolar is the autumn-winter depressive episode followed by a spring-summer hypomanic or manic swing. This maps onto circadian biology. The reduction in daylight hours in winter disrupts melatonin and serotonin rhythms, which are especially sensitive in bipolar disorder. A less common reverse pattern, particularly in bipolar 2, sees low mood in summer and elevation in winter. 2 treatment implications worth knowing. Light therapy, specifically morning bright light exposure, has a genuine evidence base for seasonal depressive episodes and can be used alongside medication. And the principle of anticipatory management. You adjust the treatment plan before the vulnerable season arrives, not after the patient has relapsed. If you know October is dangerous for this patient, you don't wait until November to change the dose. ICD-11 and DSM are very well aligned on seasonal pattern. There's no meaningful clinical difference between the two systems here. ICD-11 uses it as a course qualifier, which is the same conceptual territory as DSM's course specifier. The definition is the same: regular temporal relationship between episodes and time of year, established over time. The clinical guidance is the same: light therapy for depression, anticipatory medication adjustment. The one thing to remember for the exam is that seasonal pattern is a course specifier or qualifier in both systems. It's not describing one episode, it's describing the illness pattern across multiple years. That's the structural distinction that sometimes catches candidates out. Seasonal pattern is about the illness having a calendar. It knows what month it is. 2 years minimum. Seasonal outnumbers non-seasonal, full remission at a predictable time. The exam hook is light therapy. It's the one treatment specifically linked to this specifier. And anticipatory management. Treat the season before it treats the patient. Rapid cycling means 4 or more distinct mood episodes in the same 12-month period. And these must be full episodes, meeting all duration and symptom criteria. Hypomanic episodes need at least 4 days. Depressive episodes need at least 2 weeks. Episodes must be properly separated by 2 months of remission, or a direct switch to the opposite pole. This affects around 15 to 20% of bipolar patients, more commonly in bipolar 2 and in women. 4 risk factors drive it: hypothyroidism, antidepressants, which can actually cause rapid cycling, substances, and traumatic brain injury. Treatment shifts significantly. Valproate is preferred over lithium. Antidepressants should be stopped, and thyroid function must always be checked. Rapid cycling is the course specifier that most dramatically changes the management plan. 4 or more mood episodes in 12 months. But let's be precise about what counts. Not just bad days and good days, actual episodes that meet full criteria. A hypomanic episode needs to last at least 4 days. A full manic episode at least 7 days. A major depressive episode at least 2 weeks. And they must be properly separated, either by 2 months of meaningful remission or by a direct switch to the opposite pole. Switching straight from mania to depression counts as 2 episodes even without a gap. Who gets rapid cycling? About 15 to 20% of bipolar patients, more commonly in bipolar 2 than bipolar 1, and more commonly in women. 4 risk factors are worth memorizing as a set. Hypothyroidism. Thyroid dysfunction is one of the most treatable causes of mood instability and should always be checked. Lithium itself can cause hypothyroidism, which can then cause rapid cycling, a vicious cycle. Antidepressants. This is huge. Antidepressants can induce rapid cycling. They're already risky in bipolar, and in rapid cycling they're actively harmful. Substances, alcohol and stimulants in particular destabilize the cycle. And head injury. How does treatment change? Lithium is less effective in rapid cycling than in standard maintenance. Valproate becomes the preferred mood stabilizer. Lamotrigine can help if depression is the dominant pole, and the first intervention is often simply stopping the antidepressant. ICD-11 uses the same 4-episode threshold for rapid cycling. There's no difference there. It applies it as a course qualifier rather than a specifier, but the meaning is identical. One interesting thing ICD-11 does is acknowledge ultra-rapid cycling, where episodes shift over days rather than weeks, and even ultradian cycling, where mood switches within the same day. These aren't formal qualifiers in ICD-11, just clinical descriptions, but they reflect the real-world spectrum of mood instability that clinicians encounter. The treatment principles are the same across both systems. Valproate is the preferred mood stabilizer. Antidepressants should be withdrawn. Thyroid function must be assessed and corrected, and the threshold for intervention should be low because rapid cycling is associated with worse functional outcomes than standard bipolar disorder. Rapid cycling changes the treatment plan more than any other specifier. Lithium steps back, valproate steps forward, and the most important intervention is often stopping the antidepressant, because antidepressants can be the reason the cycling is happening in the first place. 4 per year, full episodes, properly separated. That's the definition. Here's the master comparison. DSM-5 TR has more formally coded specifiers. It's the more granular system. ICD-11 uses qualifiers and modifiers, and some DSM specifiers simply have no ICD-11 equivalent. The 2 biggest gaps. Anxious distress exists in DSM but not in ICD-11. You code anxiety separately there. And atypical features, also DSM only. The peripartum window is 4 weeks in DSM versus 6 weeks in ICD-11. Catatonia is a specifier on the episode in DSM but its own separate diagnostic code, 6A40 in ICD-11. Outside of those specific differences, the 2 systems are broadly aligned. Same patients, same clinical presentations, slightly different structure. Let's go through this table row by row and pick out what matters. Mixed features. DSM adds it as a specifier onto an episode. ICD-11 makes it its own episode type. Different structure, same patients. Anxious distress. DSM has it formally. ICD-11 does not. Code anxiety separately in ICD. That's the most important gap between the 2 systems. Melancholic features maps to somatic syndrome. Same concept, different name, slightly different threshold. Atypical features. DSM has it. ICD-11 doesn't have a direct equivalent. Psychotic features. Both systems both make the congruent-incongruent distinction closely aligned. Catatonia, specifier in DSM, its own separate code 6A40 in ICD-11. Peripartum, 4 weeks in DSM, 6 weeks in ICD. Seasonal pattern essentially identical in both. Rapid cycling same 4 per year threshold in both. Summary, content is very similar across both systems. The main differences are structural, and the 2 genuine DSM-only gaps are anxious distress and atypical features. If you can remember 3 differences, you can answer any DSM versus ICD specifier question. 1. Anxious distress exists only in DSM. 2. Catatonia is a specifier in DSM but its own code in ICD-11. 3. Peripartum window is 4 weeks in DSM, 6 weeks in ICD-11. Everything else, mixed features, psychotic features, seasonal pattern, rapid cycling, is aligned between the 2 systems.